all in different time zones, you are all most welcome to our webinar. I can see that people are still getting in, so we'll give them like 2 minutes, then we start. I would like to inform you that the way things are, if we take off those 3 minutes, we may just go a little 5 past. So please take note of that, and we'll try as much as possible to keep within time. But if we are unable, please bear with us, because we feel that this is a very important topic. So we just give them 2 more minutes and then we'll start. You are all most welcome. And once again, I would like to welcome all of you to today's webinar, which is being hosted by AfriHealth and Archist. I'm Els Chigulimaradde from Uganda. I work at Archist. I'm also the secretary for AfriHealth. Our topic of discussion today is the global health workforce crisis, moving from conflict to collaboration. We have 5 experienced, esteemed speakers who have worked in this area of human resources for health for a very long time. And they are going to make some presentations, and we will, after they finish their presentations, we'll have a question and answer session. And I'll be looking at the chat box, so please write your questions or comments in the chat box, and we'll try as much as possible to respond to them. And if some of them are not responded to, we have a blog on the AfriHealth website where we will follow up and answer or discuss the comments. So as you all know, the COVID-19 pandemic has made the global health workforce crisis even worse. It has exposed us to the need for more people working in the area of human resources for health in order to fill up the gaps. And this has happened globally. So this webinar has been triggered by the observation that there's been a silent recruitment of health workers, mainly from the underprivileged countries. And these are being recruited by governments and government agents. And these the governments are the richer or well-to-do or the developed countries, as you'd like to call them. So we feel that this needs to be discussed. And that's why Professor Maswa wrote actually a blog on this, and it has been discussed globally, and many comments have been made. And we thought, yeah, why don't we get people together and we discuss this and get ideas from you all who have come to participate. So you are all very welcome, and we'll try as much as possible to have a discussion after the presentations. And I would like to start off with Dr. Delanyo Dovlo, who is the chair of the African Platform on Human Resources for Health. He's based in Ghana, and we sent his bio, so I will not go into that. I'd like to invite Dr. Dovlo to begin off the discussion. Thank you, Dovlo.
Thank you very much, Elsie, and thank you everybody for coming into this webinar and listening in. Over the next 10 or less minutes, hopefully I'll try to give an overview of what I see to be some of the challenges of the health workforce in this current environment, some of the good news, some of the bad news, and how COVID is impacting on issues. And I believe some of the other speakers will go into more details around the issues of migration, etc. I think there is some good news in terms of the fact that the health status in Africa has improved, perhaps coming out of some of the major investments that have come out of global health initiatives. And some would argue that this remains a bit vertical and perhaps difficult to sustain. There's improved life expectancy, averaging about 60 years now. Adult mortality reducing from about 400 to 200 since 1990 per 1,000. Maternal mortality improvements registered. But also more important is there's been increased number of schools producing health workers, both nurses and doctors throughout the region. There have been some significant improvement in how in-service and continuing professional education systems have developed. And these are things that we should welcome in expanding both the numbers of the workshop, but also the quality with which they work. It is, however, agreed that while these substantial improvements happen under the NDGs, generally the benchmarks were not achieved, and Africa remains relatively weak in terms of global health statistics, but also in terms of our workforce. I was looking at the African health statistics from Afro, the 2018 version, and from 16 countries that they analyzed there, including a number of the big ones, Kenya and Uganda as well. Only Seychelles, South Africa, and Botswana seem to have above 2 of the core health workers per 1,000 population as a kind of cutoff point. And so that means that quite a significant number of countries are still well below what is needed to deliver on the SDGs or UHC. Globally, there's estimated, I think a few years back, to be a shortfall of 18 million workers, 4.2 of which shortfall is in the Africa region. When you look at that and you take it out of the 18 million and maybe you add about 7 million in Southeast Asia shortage, there's a core 11 million, 7 million thereabouts shortage in the rest of the world, a lot of it will be in the developed countries. And the challenge is whether we'll be required to contribute to filling that gap as well. And so these are some of the challenges that exist. There are still issues of poor deployment, inefficient utilization of staff. There are issues of motivation, incentives, and remuneration levels that remain quite low compared to other parts of the world. The fact that even with the expansion in the numbers of production of health workers, what has happened is there's quite a bit of unemployment. I think in almost every country where this expansion has taken place, the unemployed nurses and doctors. In my own country, sometimes I understand it takes almost a year after qualification for a doctor to be employed. And so the question is whether the Code of Ethics on International Recruitment would impact on these things. Are we going to have to lose these unemployed workers to other places if we are unable to take them on ourselves? However, some recent work I cited indicated that they've seen a 21% reduction between 2004 and 2014 immigration rate.
Please mute if you are not speaking.
Yes. The interesting thing is that from a recent study I've seen, Adovo and Co., that immigration rates have declined by 21% between 2004 and 2014 for physicians out of Africa. And so there's some positive there around maybe being filled by migration from other parts of the world. But at the same time as this unemployment and yet low ratios of health workers to population exist. So I come to the issue of COVID-19 and some of the issues that have arisen in my mind and from where I sit in Accra, Ghana, and seeing the impact here. One of the major things has been the mobilization of the workforce and also significant mobilization of the unemployed workforce of nurses and some of the graduates that have been redundant, particularly for the huge effort at contact tracing and testing that has been going on. The second has been the development of incentives for frontline workers. Now, defining those frontline workers has been quite a bit of a challenge and has been resulted in a bit of back and forth between various types of health workers. But this has resulted in about the equivalent of about $25 per day payment to contact tracers. There's also the president has decreed a 50% pay increase for all frontline health workers. And then all health workers are expected to enjoy a tax-free, income tax-free remuneration for 3 months, which should end about the middle of June. We wait to see what will happen after that. But also important are things like the ramp up in local production of protective gear for health workers, which was quite useful. Now that we can import these things, there's been quite a lot of effort to get them produced locally, and that has happened. However, some of the other things is that because of the high demand on ICU, ventilator management, and so on, a lot of the workforce has also moved towards providing services in this area. And there is a downturn in the appearances of people suffering from the more mundane regular illnesses that we see. And it's not clear what the impact of that will be overall at the end of this. COVID, like Ebola, has also seemed to impact health workers quite a bit with quite a few infections. I'm unable to tell how that is in terms of ratio to the overall number of positives that we've had. But we've lost quite a prominent health professional, the director of our postgraduate medical college of all people, to COVID. Some hospital units, major hospital units, have had to close down because physicians or other health workers are tested positive. And so all sort of effort had to go in, things that were not particularly needed. And then it has also raised the issue of our, what I would call the health security workforce, the people who do the contact tracing, the sample taking and testing in the labs, who run the ICUs and the isolation staff. You remember that one of the major challenges is the paucity of ICU and high dependency unit beds and equipment in our region. And the issue is, if you're going to have more of these pandemics, how do we create and sustain a standing workforce that looks at the health security? On the other side is the fact that COVID targets certain vulnerables, the elderly, those with coexisting NCDs in particular situations, and also what this means in terms of our efforts at health promotion on a wider scale to make sure that people with these things are taken care of. It also revealed a number of nuanced capacity needs. Some of these are lab technology, for example, research and analysis, and policy advice has been a challenge. The epidemiologists and the epidemiological statistics, community engagement, and social anthropology has been an area that has been particularly challenging, linked to the risk communication and how populations take up the challenge of COVID. And part of these, I thought in my mind, has been around the interface between politics and health as this has gone on, and how independent analysis that may be against the way maybe government wants to move, or certain interests want to move. And I'm sure you've all faced the challenge of economics versus managing the pandemic, and should we open, should we continue restrictions or not? And that has been part of a major part of our existence here. There are also the issues of whether we can survive the removal of the new incentives that have come with COVID. We have, rather than increasing public health infrastructure and staffing, announced an investment in a large number of new hospitals and ICUs. So again, what does this mean for the future? The issues of population engagement, understanding capacity that is three-dimensional, not only in having the expert, but the right numbers, and also making sure that the competence is high and sustained. And so in terms of migration, I guess, as it was said in the introduction, the global demand remains. And also we need to watch out for the value of those basic health workers that nobody thought were very important before, and how we keep them under very difficult circumstances. With us in Ghana, I think with the ban on travel, it's not been very easy, though we are aware that people have relaxed visa requirements, and this has come out quite openly about encouraging health workers to come. I think that was the US in particular. And so the challenge is there, that as this resolves, will there be an uptake of health workers from our region? And so to conclude, the question I have in mind is the code of ethics that we all use around migration of health workers, around recruitment, ethical recruitment of health workers, still relevant? And what would it mean in a situation where there are a lot more of global or other limited pandemic situations that do not spare countries, whether rich or poor? Thank you very much for giving me the opportunity. Over.
Thank you very much, Dr. Dovlo, for those remarks. And please keep your questions for later. We'll have time for questions and answers and comments, but you may start writing them in the chat if you have them already. As I told you earlier, we shall change the sequence here a bit. So Ibadat will speak later. Right now, I would like to welcome Professor Francis Omaswa, who is the Executive Director of Artist and has worked for decades in this area of human resources for health, to make his presentation. Professor Omaswa.
Good morning, good afternoon, good evening, everyone. I'm glad to see faces there, geocallers, I can see you. And so on and so on. So I have slides. How am I going to show them? Oh, glad to see so many of you. Oh, great, great, great. Oh. My slides, please.
You had said you share your screen. Should we show them from AfriHealth?
Please do.
Okay. Clara, could you please bring up Professor's slides?
So as the slides are coming up, this webinar has been triggered by COVID. We have seen, I have personally seen advertisements for health workers from Africa, also from the Caribbean, by recruiting agents and by governments. And these recruitments have not been consistent with the aspirations of the WHO code on the international recruitment of health workers, about which we will hear later. And I saw this as a crisis which will threaten our ability to cope with COVID, taking into account that at least here in Africa, the epidemic is very likely to come. And when it comes, we need all hands on deck, our own and those of our friends around the world. Can I have the next slide, please? So I will go quickly. The message here is that this is important. It's about everyone accessing the health care that they need and the health workers that they need. And our job in this webinar and after the webinar is to work to create a climate of opinion which will make these aspirations possible around the world. So I am familiar with this global health workforce crisis. I was a full-time employee for some years at WHO as the executive director of the Workforce Alliance to promote solutions to the code. And the main message here is that we have demographic realities from which we cannot run away. We have economic realities which we cannot run away at the moment. The populations in rich countries are living longer, they need more health workers. At the same time, the young people are not many. They will go to the banks and maybe other places. Sub-Saharan Africa had a surge of infectious diseases with a rapidly growing population applying pressure on the health system. And WHO estimates that by 2030, we will be short of 18 million health workers. And this subject was for a long time swept under the carpet. It was seen to be complex, wrong policies were imposed, which contributed to worsening the issue. And above all, there was a big struggle, big conflict. Next slide, please. That just shows you what I was saying, the Uganda on the right side and Japan on the left side. Young population in sub-Saharan Africa and Asia, and aging population in the developed countries. Next. So what really led to the creation of the code, I attended meetings regularly at the World Health Assembly. I also attended meetings at the British Commonwealth Health Ministers' conferences, and I witnessed very ugly quarrels between health ministers from the northern countries to those from the southern countries. The African countries were led by the late Dr. Shabalala, who was Minister of Health from South Africa. And it forced 3 times in a row debates and resolutions at the World Health Assembly, which were not on the agenda when the assembly started. In the end, they say, okay, let's stop quarreling, let's stop conflict, let's agree, let's have a code. We get a global pool of health workers, which we share through the code. And that is how the code came to be. Next slide, please. And there it is. It took a long time to develop. I was coordinating the development of the first draft, but 6 years later, I had also now left WHO and the Workforce Alliance, but still participated in getting this code adopted. Now, what is this code? There are only 2 codes like this. There is this one, and about almost 40 years ago, another code on breast milk substitute had been adopted. And next slide, please. And the code is voluntary. It is expected to help in addressing the global crisis of health workers, which is characterized by shortages, widespread shortages, maldistribution, and poor working conditions. And the code was to address that conflict between health ministers from the north and south, and it would take into account the rights, obligations, and expectations of both countries from where the health workers come from to the destinations countries, but very importantly, the code also addresses the rights of migrant health workers when they are recruited in the destination countries. The code would be used for negotiating bilateral agreements between countries or multilateral agreements, and it would also be used in achieving what we started to talk about at the beginning, better health outcomes for everyone, access to skilled, motivated, and supported health workers by every person in every village, everywhere. That's one of the slogans. Next. However, when the code was adopted, the adoption was unanimous and it was very enthusiastic, and we all stood up at the World Health Assembly when they announced the passage of the code. But then, lo and behold, the year when the code was adopted, WHO had money problems. They closed the Health Workforce Department. Also, the Workforce Alliance, where I was working, also lost support, but it is now still in existence as the Global Health Workforce Network. CSOs, which were supporting advocacy, were also underfunded, and so on and so on. The effort went down. But good news is that there has been a new effort now connected with SDGs and so on. So the department at WHO is back in place with staff. They could do with more staff, a lot more staff. The code is reported on, the code is being regularly reviewed, and WHO just issued the latest report of the review of the code, which I'm sure Ibadat will be talking about from WHO. Next. Some countries have been implementing the code even during those times when there was instability. The Philippines in particular had a long history, or has a long history, of a policy on training and exporting health workers, and have these agreements. There are also many others which I have not listed here, between South Africa, like, and the UK, between, for example, also Kenya and Namibia inside Africa, and so on. So this has all been happening, but in my view, not in the way in which the code was envisioned. Next. Now, another very powerful move which has given us a new hope is the establishment by Ban Ki-moon, the Secretary General of the UN, of this Commission on Health, Employment and Economic Growth. And the main outcome of this high-level commission are two things. One, investing in health is productive. It's not a cost. And this was traded for many years by other people. Health workers are employees. It is jobs for people, jobs for women, and they contribute to the economy of the country. The health economy is something which is quite significant, and every country should look at it as such and not as a cost. And of course, now with COVID, I hope that argument does not need to be peddled too strongly. Next. And this is another development following that commission. We now have a platform on the international on health worker mobility, and these are working to promote this agenda. Next. Also, World Trade Organization has got resolutions and technical guidance on trade in services. And this includes all this cross-border export of services, and also presence of what they call natural persons, where professionals move from one country to another. Next. Let's move quickly on that. There are several things there. What that one is saying, next, touch. Basically, this is all supporting the code. This is all supporting the code. It's basically saying that according to the recommendations of the World Trade Organization, legally binding guarantees can be provided to migrant employees, either through the regions or through global. And it includes all these people whom we are talking about. Next. The Global Health Workforce Network, I have spoken about it already. It could now be the forum which rallies us around this topic. Next. And we are now moving towards what is called orderly and safe migration. And already for this code, there are many bilateral agreements which have been notified to WHO, but we haven't analyzed this enough. They are not as effective and as adherent to the code as we would like. In my country, Uganda has a legal framework, and there are so many recruitment agencies there, but they are compliance with the code is weak. And this is very important. I'm now going to touch on the question of how can we create a pool of health workers which we share through the code. We can only do this if we have education mechanisms which produce accreditable health workers, the accreditations of which can make them portable around the world. And this is, there is a strong movement on this as well. Let's go to the next slide. The ECFMG of the US and the World Federation for Medical Education have proposed that by this next year or two, accreditation will be done through regionally recognized bodies. In East Africa, for example, we have between about 5 countries. The regulatory bodies are amalgamated. They supervise the trainees together. They revise the curricula together. And this is the vision which we would like to advocate for, so that graduates from those institutions have gone through a curriculum which has been approved by the World Federation of Medical Education, and they then qualify to be portable health workers. Next. So there are new movements on this. The UK have a group called the THET, the Tropical Health and Education Trust, and they have issued a report about 2 years ago, a year ago, and what they are saying, this is the UK now. They recognize in that language there that the people who go to the UK from the developing countries are needed in their countries more than they are needed in the UK. So they are now engaging with their government to see that something is done about that. And they have 7 recommendations in the report. I had inserted a link to that, to their report there, but it's not reflected. Germany has gone even further than the UK. Germany has set up in their Ministry of Foreign Affairs and Ministry of Health structures to manage recruitment of health workers from abroad in a all of government system, which would be a model for other countries to follow. Next. Civil society has a big role to play in this, and these are some of the players there. That network, the African platform, the Asian coalition, PAHO, there is a health workers for all coalition, frontline health workers, and we have global health workforce forums every 4 years. And this is my last slide. It is just an appeal to all of us to prioritize the topic of health workers so that they are seen as a global public health good. And we need to support advocacy for this code if we are going to achieve this. We want to fund WHO and other agencies to advocate and move this code. We want this to become a political issue over which elections are won in some of the countries, because some countries have really got big issues with health workers. And then let's educate that large pool, invest in education across the board. When the code was passed, countries like the USA said they would train 140 health workers. That's how we got MEPI and NEPI. Japan, the same. The Scandinavian countries, the same. But all that has declined. We need to go back to it. And we really should see that we work together, a health worker for everyone, so that equity and social justice is there for all people, wherever they live. Thank you.
Thank you very much, Professor Maswa, for that presentation and for highlighting what the WHO code is all about. And for that appeal, we all really need to get engaged in this and see how we can produce more health workers for all of us. So next, we'll go on to Jean-Christophe Dumont from OECD. Thank you so much for allowing to join this, for agreeing to join this webinar. Would like to hear from you. So please go on and give your presentation.
Thank you very much. Thank you very much for the invitation. I will try to share my screen now. Tell me if you see my slides. Do you see my slides?
Yes.
Yes.
Okay. So thank you very much for the invitation. It's a great pleasure to be here with all of you for that webinar. What I will do in the next few minutes that I have is to share with you some updated information on immigration of doctors and nurses to OECD countries and put that in the context of the adoption of a code and of a discussion of the advisory expert group that, as Professor Maswa just said, given its recommendation to WHO for adapting the code. So I think this overall figures for the 37 now OECD countries show that clearly the number of foreign-born or foreign-trained doctors and nurses to the OECD is first of all non-marginal and has been increasing over the past 15 years or so, despite the adoption of a code. As you can see here, we now have about more than a fourth of all doctors practicing in OECD countries who are foreign-born, and about a sixth of nurses who are foreign-born. Numbers for foreign-trained are lower, but show exactly the same pattern. They are lower for a number of reasons. One being that obviously some people arrive to a destination country at young age and do all their training in destination country. But there is also the other part of the equation, which is that, as it was said before, there are many obstacles for international transferability of skills and qualification in the health sector. And therefore, a number of people have to retrain themselves in the destination country. So they are foreign-born, but not necessarily foreign-trained if they have to redo their medical education. In any case, the trend is clear. It's on the increase, which makes the code, WHO code, more relevant than ever. Obviously, this question of health worker migration should be looked at in the broader context of highly skilled migration to the OECD. In the past 15 years, the number of tertiary educated immigrants in the OECD almost doubled. And as you can see here, about 20% of all tertiary educated people in OECD country, 1/5 are immigrants. So what you can see here is that the blue bar is slightly higher than the white diamond almost everywhere, meaning that the share of immigrant doctors is higher than the share of tertiary educated in overall immigrant in the overall population. But the two things have to be contemplated in the same perspective. OECD countries are competing for talents, and doctors and nurses are among these talents. But there are a number of specificities, some of which are addressed in the code, some of which are not addressed in the code. And part of a recommendation of the expert advisory group has actually been to extend the scope of the code to some of these elements. One very prominent feature in the health context is the increase of internationalization of education. Indeed, we see in a number of contexts where it be in Asia, in the Philippines, it was mentioned, and it's a well-known example, but we have also international education, medical education in the Caribbean. We see that trend in Europe very strongly between EU countries. And this is obviously playing an increasing role in the trends that I've mentioned. The second point, which is on which the code was not entirely silent, but not very loud, is on the role of these intermediaries, the recruitment agents, which are in many cases not regulated and can indeed act against the, let's say, the spirit of the code, if not against law in some cases. Persistent obstacle to international transferability of skills and qualification. This is not specific to the health sector, but as I can tell you, about 1 in 2 tertiary educated immigrants in the OECD is either inactive, unemployed, or overqualified in his or her job. The figures for doctors, nurses, but also all other health workers are much higher because of additional requirements, be they due to language proficiency or to supposed non-transferability of education across jurisdictions. So this is a very important obstacles. And in the context of the COVID crisis, maybe what we've seen is that a number of countries have actually taken actions to reduce some of the barriers for internationally trained doctors. This is the case notably in a few provinces in Canada, in Ontario, where they offer temporary licensing of doctors with foreign degrees, New Jersey in the US, or in Italy. There are also cases where the requirements for language proficiency have been eased, like in Germany. Other cases where the number of years in terms of internship has been reduced. And this is the case of New York, Massachusetts, Utah in the US. And also in a number of cases, which is a bit, let's say, paradoxical, cases like France or Ireland, there has been facilities for internationally trained doctors to work in the health sector, but not as doctors, maybe responding to phone calls in telephone centers or helping in other ways. I think countries are realizing that there is an untapped pool of skills in their country. Sometimes they are asylum seekers, they are recently recognized refugees, they are people who are in the education pipeline to redo their education, and they are started to tap in this pool. Whether this, let's say, facilitation will remain after the COVID crisis remains to be seen. But I think everybody recognizes that there is a big issue here. And obviously, they are concerned about the impact on countries of origin, and on that I will come back in a minute. In the overall OECD countries, about a third of foreign trained doctors and a bit less of foreign born doctors are actually coming from other OECD countries. So the movement is not only south-north, is also quite intensively north-north. But as you can see on this graph, the dark and light gray show countries of origin which are lower middle income country or low income country. And as you can see, for some countries, I'm thinking notably about the US or the United Kingdom, to some extent also Ireland, the share of migrant doctors who are coming from lower middle income country or low income country is very significant. When we look at total numbers by country of origin, what you can see is on this graph, this is really the latest data you can find. There are about almost 100,000 Indian or doctors born in India working in the OECD. About a third of that from China, 26,000 from Pakistan. So what you see very clearly in this graph is the big country come first of the list, obviously. India, China, Philippines for nurses, Nigeria also for nursing, quite high in the list. You see mostly Asian countries where obviously they are highly populated countries, and some of them have specialized in training for the international market in recent years. But when I look at the same numbers as a proportion of a country of origin, meaning when I'm looking at immigration rates, obviously different set of countries emerge. As you can see, for China, the numbers are big, but as a percentage of their whole health workforce, immigration to OECD country is extremely low, to say almost zero. For India, this is slightly higher, but still fairly lower than 10%. What you see on this graph is appearing a number of obviously Caribbean countries, that's well known, but also African countries. You see Malawi, you see Ghana, you see Zimbabwe, you see Liberia, you see Gambia, you see Cape Verde, and Congo, Senegal, and Cameroon as well. French-speaking country are appearing on this graph as having above 30% immigration rate of their doctors. For this country, obviously, the impact is extremely sizable. The good news, as Dr. Dolvo said before, is indeed that for some of these countries of origin, the trend is positive, meaning that the change, as you can see on this graph, the change in the number of native-born doctors working abroad has been lower than the change in the total number of doctors at home. And that's why you see for low-income countries of origin here, that's the change in number of doctors working in OECD increased by about 30%, but the number of doctors at home has more than double. I think we can see some of the efforts paying off in terms of increasing the education. That being said, the increase is still not marginal at all, plus 25–30%. For countries with very fragile health system, this is still a very strong matter of concern. That's why the OECD comes with a set of recommendations, first of which is please pay attention to the code, implement the code, and in its full scope. Second, continue to increase training capacity in receiving country. I think medical education has been increasing in most OECD country, and nursing education as well. This is not necessarily true for all specialties and for other type of health workers. Also, there are big maldistribution issue that needs to be addressed according with relevant working conditions. Ensure that migrant health workers have equal working conditions than other health workers. This is in practice not the case. They are overrepresented in atypical form of work like night shift, weekends. They have lower pay than other health workers. They need to be treated exactly the same for the same function. And their role should be acknowledged as key elements of the sustainability of national health system. Again, in the COVID crisis, we've seen some of that. We've seen voices raising to say how migrant health workers have been helpful. I think we hope that this will remain in the public debate as such after the crisis. Address the brain drain issue with appropriate recognition of skills and bridging courses. But last and certainly not least, I think we want to be a key advocate for increasing overseas development assistance and technical assistance. Because as it was said by Professor Omaswa, this is a global issue that requires a global and coordinated solution. Overseas development assistance spent on health is not huge. Spent on health workers, it's very, very low. And that needs to be addressed and increased. Thank you very much for your attention.
Thank you very much, Mr. Dumont, for that presentation and for highlighting the data. That is really good because we can see what is really happening. And it's unfortunate that in most of the countries where the migrants come from, the data is not available. So that makes it really difficult even to know the extent of what is happening in the countries that are losing the health professionals. And also the issue of equity, which you've talked about, and also Dr. Dovlo also talked about this. Emphasizing equity for the migrant health workers is also a very important issue. So thank you very much. We'll go on to our next presenter. And please, if you have comments and questions, please put them in the chat box. We'll be able to address them at the end of the presentations. Okay, so we'll go on to our next presenter, Ibadat Dillion from WHO. He has also worked in this area for a long time, even before he joined WHO. So Ibadat, you are welcome to give us your presentation. Thank you.
Thank you, Elsie. I'm sharing my screen. I hope you can see it.
Yes.
Excellent. Thank you for hosting this webinar, and thank you for inviting me to speak. I think it's an honor to speak, especially on this panel. I will keep my presentation relatively brief. I will go through the slides quickly because I think many of the issues have already been covered. As we start, I don't know if you can see the whole screen, but as we start.
We don't see the whole screen. Could you reduce probably on the side so that we see all of it?
Okay, 1 second. Do you see the whole screen now?
Yes.
Okay, thank you, sorry. As we start, I think it's important to recognize that this is a challenge that has been raised for a long time. And last evening, I was going through old UN General Assembly resolutions, and I could see that this issue was really, really prominent in the late 60s, early 70s, going into the 80s. So this is a resolution at the UN General Assembly in 1973. These are the operational paragraphs where the member states, as a matter of urgency, called for the formulations of policies to mitigate the adverse consequences associated with brain drain. They called on developing countries to make a thorough evaluation at the national level of the special characteristics of the brain drain problem. And they urged developed countries to support measures designed to encourage the absorption of trained personnel within developing countries and to support the activities of the international organizations aimed at finding solutions to this problem. So really, this is almost 50 years ago, but I think extremely relevant to what we are discussing today that links to both the three presentations before this. And I think the same issues stand ahead of us, and from Jean-Christophe's presentation, it is perhaps the scale and complexity of it that is increasing and making it even more of a priority to focus on now. I won't go through the 18 million, I think we've gone through this, but since the analysis, when we looked at the need for 18 million additional health workers, we can see a very significant demand coming from OECD countries, and linked to, again, what Jean-Christophe was presenting and Professor Omaswa was speaking to, where the demographics and the epidemiology, and now even more so the additional of health emergencies, is increasing both the demand and need of health workers in wealthy country health systems. It's in this context, I think we are fortunate to have something like the WHO Global Code of Practice. It is one of only a handful of international legal instruments in WHO's stewardship, and all member states negotiated and subscribed to it. I won't go through the substance as Professor Maswa has already done this, but just want to highlight how important the legal and institutional arrangements that are incorporated in the code have been to whatever success has come from the code. And this did not have to be. This was definitely something very much pushed by African member states, so that to really elevate the status of the code, with many countries believing that such arrangements should not be in place for a non-binding instrument. But in the end, the process was put in place that every 3 years, WHO has to report on progress on the code. And every 5 years, the member states, which is highly unusual, are part of the process to review the code's relevance and effectiveness. And I think Professor Maswa spoke about the birthing problems of the code. And it's really because of this legal and institutional arrangement embedded in the code that the code is still with us today as a tool. I will continue. And over time, we can see that the quality, quantity, and diversity of the reporting on the code is improving. At the same time, many of the countries that are most challenged, as Jean-Christophe just made clear to us, both in Africa and the Caribbean, and many of the same governments that had pushed for the code have engaged the least with the code. A couple of years ago, we received resources from the EU to work on trying to better understand and implement the code in a few countries. We worked with HWF in this process, and through our joint work, we could see that there's a lot of mobility within the South itself. So a lot of movement within the region. We just heard, for example, about harmonization in the East Africa community. So when we looked at data in Uganda, we could see that there's a significant movement of Ugandan doctors within East Africa, and after East Africa, then to Southern Africa. And so based on letters of good standing being pushed out by regulatory councils, we could see that almost half of those were requested by other African states. Similarly, when we looked at data in South Africa, the biggest source of doctors to South Africa from the Congo, and also the numbers 3rd and 4th are from Cuba and Nigeria. So there's a lot of movement. When we looked in Kerala, in India, we could see that from a migration study that was done there, that about half the immigrants were moving to the Gulf. So really a complex movement within the South as well, with a lot of Nigerian and Indian doctors also present in the Caribbean to work there. Simultaneously, I think as Jean-Christophe mentioned, we can also see this similar trend of internationalization of medical education and the issue of temporary mobility, where people are being registered in multiple jurisdictions and moving back and forth regularly. I think this is linked to both Jean-Christophe's presentation and Elsie's of the need to actually try to strengthen data, not just in OECD, but to try to get the richness of information that is held by OECD countries to also have this available from other countries. And from reporting on the code, we could see, and through NHWA, we can see, for example, that a number of African countries that reported actually themselves have significant reliance on foreign-trained doctors and health professionals. So just for example, Namibia, Uganda, Nigeria, Zimbabwe, Mozambique, all have significant reliance on foreign health workers. Namibia, 90% of the doctors are foreign trained. Zimbabwe, we always think of a source country, but 50% of the pharmacists are foreign trained in Zimbabwe, 17% of doctors. So really, it's putting additional pressure on the ministries of health in their stewardship function to both try to manage the movement out of the country, but to also think about how to maximize the benefit from the people coming into the country and how to fill gaps in the health systems linked to this. This is data from Qatar, but again, simply to say how important data is to our discussion and how the links between the countries is different based on the occupations we look at, whether it's doctors, nurses, pharmacists, or dentists. So in the case of nurses in Qatar, it's largely Tajikistan and Ghana. But very different picture for the other occupations. So really, over time, the more information we get, I think the better our dialogue and discussion will also improve. But in addition to getting better information through the code reporting process, the code is also, over its 10 years period, and in part sometimes due to the role of the Secretariat, but often not due to the role of the Secretariat, is being used strategically by member states to develop national policies. And national policies that often the Ministry of Health usually does not have the mandate to engage in. So, so one example is in South Africa, where there's the recruitment function has been mandated into the Ministry of Health, and which was previously in Home Affairs. And across the board, we can see the adaptation of national migration policies into national health worker migration policies in country. We can see policies related to recruitment, and we can see code allowing code being to negotiate in bilateral agreements where otherwise Ministry of Health may be not as directly engaged. And this is a slide that again shows links across countries of bilateral agreements that we have captured at WHO, both through the notification through the code and our own collection. And similarly, we see a very complex movement of complex partnerships across countries and within regions and outside regions. A key point here is we also have countries have also shared texts of about 40 agreements with us. And when we look at them, we can see that the form is diverse, the context is diverse, and the goals are diverse. Oftentimes, the goals are employment, their trade, their education, and sometimes they are health. And sometimes health ministries are involved, but often health ministries are not involved in the negotiation of these or the signature of these agreements. And this is work that OECD, WHO, and ILO, we will work more on trying to get a better sense of this and guidance around this. Next slide. Again, this is simply to show just how complex the discussion is, how many partners there are in the question of mobility. And really the importance of the code in this context is that it puts in central the need to focus on health systems as part of the process. And this is hopefully can empower our ministries of health in the dialogue they have with their counterparts. And to quickly get to finalize or to finish up, all this information and more went into a process where there was an expert group review following 10 years of the WHO Global Code of Practice. It had senior government representation from 12 countries. It also had independent experts. Many on this panel were on that review. And the key findings were that the relevance of the code is high and growing. The effectiveness is, there's more and more information of effectiveness, and so there's strengthened evidence of effectiveness of the code. However, there are critical gaps in implementation that is compromising the realization of the code's full potential. And really, the next period needs to focus much more on this, and with the focus especially on the countries that are most in need. The group also looked at updating our former list of countries with critical health workforce shortages to really identify and target support and safeguards to the countries with the greatest health workforce vulnerability. The group also wanted to make sure not to see the code just as a regulatory instrument, but fundamentally something that should drive support. And I think the previous speakers all raised this point. And there's a very important study from the University of Washington that shows just how limited the development assistance of health over the last 30 years, how limited it has been in putting effort towards human resources for health and in human resources for health for the long-term sustainable education and employment of health workers. And the group also spoke about the need to make sure that active recruitment safeguards are in place. All this information is available through the link there and will be discussed at the assembly when it continues. And I think we already saw this, but we're trying to work with ILO, OECD, and other agencies and other member states and private sectors, civil society, trade unions to come together and try to capture as much good practice and information as we can to be useful for hopefully to maximize the benefit and minimize the negative effect from migration and mobility. And I'll stop here. Thank you.
Thank you, Ibadat. Yeah, it looks like the demand for health workers is really high, but the supply is not matching the demand, so more needs to be done. I want to apologize that we are going to continue beyond time, but I can see that comments are going on. Please bear with us. We shall finish a little later than we had thought we would. And last but not least, I would like to welcome Dr. El-Sheikh Badr from Sudan, who worked with the Sudan government for a long time, and is going to give us a case presentation on this topic. El-Sheikh, please.
Yes, yes. Thank you so much. May I share the screen? I think I have a problem here. If you can put my presentation.
Okay. Clara, could you please?
Okay. So I think it might. Is it coming now or?
We are just seeing Zoom.
Okay.
But we could ask Clara at AfriHealth to share your presentation.
Okay.
Okay.
Yes. Thank you.
Thank you, Clara.
Next slide. So I will be quickly going over our experience in Sudan with managing health worker migration, mainly through bilateral agreement. The challenge we had in the country is that health worker migration is massive in Sudan. We estimate it at a rate of over 60% among physicians and maybe less among other health workers. Our trends are increasing in Sudan, and the trends are usually are recently towards more regional markets in the Gulf. That's why it's not showing very much in Western countries in recent times, but mainly to Gulf countries, and in particular, Kingdom of Saudi Arabia, where we estimate that we have now over 15,000 Sudanese physicians working at the Kingdom of Saudi Arabia. We have the agreement between Sudan and Saudi Arabia that was signed in 2016, and the agreement actually it came at the along the lines of the Global Code, and it covers 3 dimensions. Number 1, formal channels for recruitment, because we had previously active recruitment through recruitment agencies, which was largely unregulated and unethical. The second dimension is the training for residents. We included that, and I think that was quite innovative. So we have exchange of trainees between the 2 countries, and mainly through enabling Sudanese residents to be placed at big hospitals in Saudi Arabia, for training. And then we had also locum opportunities for medical specialists and consultants, which is like short-term employment to obliterate long-term migration. We had joint mechanisms for implementation and monitoring, and the impact, I would say, is positive with so many things. Because of time, I cannot elaborate, but it was positive amid of the challenges we had. The main lessons from the bilateral agreement we had, I think it has been a negotiation game. It hasn't been a straightforward, issue, like we have a code and then we just strike agreement. No, it was really tedious negotiation game. And lessons we had is that ethical call alone is not enough. So countries usually mind their interest. And I think this is largely seen now. The second issue is that the code is not automatically the solution. The code is a guidance, but a lot of practicalities are needed to strike agreements. Then also handling health workers is a tedious issue. While you are negotiating with countries, you also need to negotiate internally with your health workforce, because health workers are not like inanimate objects. I think they are really, they have their own agenda, and sometimes that agenda might not fit in with the national agenda. I mean, in terms of the aspiration to move and to migrate and to support their families, and a lot of legitimate issues. Practicalities and negotiation skills were heavily called for, and I would say even this is a lesson for those who work in health systems. I think a great deal of diplomatic skills are needed to deal with this issue of mobility. Another lesson we have in the country is leveraging political support. Our agreement was actually mainly enabled through higher level political support between the two governments that transcend to the health sectors in both countries. And also the importance of building both formal and informal links and looking for entry points. So these agreements are not actually like formalized issues. They need a lot of relationships and entry points to get there. Persistence and flexibility are also called for, because in Sudan we have tried for several years to strike this agreement, and it took us nearly more than 6 years to do it. And there is also the importance of providing wins. So any country needs to see what are the wins. Maybe an overarching lesson from our experience is that thinking around mobility has to move from condemning the phenomenon to appreciating it, appreciating the mobility as a reality, regulating recruitment, and promoting collaboration and maximizing benefits. So I think we need to shift that way. Thank you.
Thank you very much, Sheikh, for sharing that Sudan case. And yeah, this really speaks to our title, From Conflict to Collaboration. So there's that need for us to work together to make things better. So in the meantime, there's been some on the chat box, there are some comments and questions. I'll go through some of them. Ben Sims from DET says, stopping migration of health workers is not going to happen and may even be undesirable because individuals have the right to progress their careers. The challenge, therefore, is to shape migration in a way that brings mutual benefit. And so that organization has a report, the IRL is there, so please go to it and look at and have a look at it. But there's also, Wako Nicholas says, the discussion is about doctors and nurses. What about allied health professionals and probably Professor Maswa or Sheikh could say something about that, because we know that the migration is not limited to doctors and nurses. It's affecting all health care workers. Maybe you could say something about that before we go on to the next comment. Sheikh, would you like to say something?
Yes, if I may comment on this, I think that, yes, that's the right type of observation. And probably in our context, at least, this is explained by the issue of mutual recognition of qualifications. For example, medical education is actually well developed and is internationally recognized, unlike nursing education and other types of allied health professions, which is largely local. So that's one, in our context in Sudan at least, that's one of the reasons. And I have seen now in some of the presentations this issue of international portability of qualifications is actually one of the challenges in the blocking the exchange of other health workers. But again, in our context in Sudan, also we are seeing now increasing movement of nurses, pharmacists, dentists, and others, because regional markets are expanding and they are in need of more health workers. And sometimes country, opt for removing caps sometimes, and because they are in need of health workers.
Thank you, Sheikh. And I know that in Uganda, I'm a radiologist, so I know about radiographers. Radiographers are migrating to mainly the UK in very large numbers. Almost a whole class qualifies of about 30 people, and half of them leave. Professor Maswa, any comment on that?
Yeah, allied health are part of this. They are in many situations even in bigger demand. Laboratory staff, physical therapists, radiographers, as you have said. So they are part of the discussion, all the health professions. And Dr. Dovlo also pointed out earlier that this group is being brought forward by COVID more than we appreciated before. So all of us are in. Do you want me to comment on Ben Sim's?
Yes, please go ahead.
Absolutely. Health worker migration is inevitable. That's why we are talking. All we are saying is let's do it well, in such a way that all people are receiving the health workers that they need. It is desirable. It is inevitable. We have to do it because of those demographic and economic realities which we live with.
Okay, thank you. And Joe Collars, could you please give a comment? Joe, you had said you'd say something.
Yeah, greetings, colleagues. First of all, my compliments on just an excellent webinar. In these times, we're all doing social distancing, but I think webinars like this and be able to see some of your faces, hear some of your voices is helping us with distant socializing, which I think we need to do more of. I'm again inspired by the quality of the conversations that are taking place. Coming from the US, I'm at University of Michigan. I think we're turning to Africa and the continent to see what are the important lessons that are being learned there. I think we're starting to see in the United States the products of many of our probably flawed thinking about not optimizing the alignment between our workforce and our health system. We're not looking very good right now in terms of how we're responding to the pandemic. Some of it is leadership decisions, but I think a lot of it does reflect on how our balance of our healthcare workforce isn't optimal to the situation. I think this is a powerful time for Africa and the continent to be able to teach the world on how to think about these issues more critically. So I look forward to continuing conversations and from learning from all of you, and know that I'm an eager partner as people try and find a way forward. So thank you, Elsie, for bringing me in.
Thank you. And Kamanzi has made a comment there about the harmonizing of curricula, producing quality educators, improving the infrastructure and logistics, especially in the developing world. And he's asking, he wonders how all of these high-level policies could be narrowed to meet these endless needs that are common in many developing countries. Does anybody want to react to that? The panelists?
Well, one of the challenges of this health workforce agenda is the governance of health workers. In most African countries, the structures for governing health workers are weak. The Ministry of Health employees who look after health workers move from ministry to ministry. They have no technical background in health, linking health skills to disease burden and so on. So you find, like Dr. Dovlo said, they qualify 1 year later, they are not employed. They go to the job 1 year later, the payroll has not worked, they are not paid. And we complain about our health workers moving out, but it's more of a push than a pull. I believe most people would rather be at home, but they have to move because they don't like their lives when they are in their countries.
Yeah, thank you. Patrick Kadama from Uganda is asking Ibadat that what is the WHO doing about the health workforce issue in the COVID-19 era, especially in continuation of the 73rd WHA agenda later this year. Ibadat, would you like to react?
Yes. The code is actually on the agenda item of the 73rd World Health Assembly. In this current context, it was only the discussion, very, very abbreviated part of the assembly that was suspended, with the assembly to continue later in the fall. It's still not clear whether the assembly will continue in a virtual manner or whether it will be an in-person meeting or the dates of when we will actually convene again. But it will happen likely in the fall, and the code is one of the agenda items that will be discussed there. And I'm sure it will be discussed also in the light of the COVID context. At the same time, the health workforce issues are extremely prominent and are coming up very much. They came up in the discussions on COVID. The Philippines raised also the issue of the code in the discussions on COVID. And it was, I think, yesterday, the day before yesterday, that EU DEFCO and Dr. Tedros wrote a blog about the need to invest in health workforce and infrastructure as fundamental to the COVID response. So I believe that actually the health workforce issues are as prominent today as they've been in a long time.
Okay, thank you. So Brian Pearson says, why not an international agreement whereby a fair price is paid for the training institutions from HRH working elsewhere, whether north or south or south-south? This would be equitable, balanced, and it would provide critical investment capital for training. Dovlo, Professor Maswa, any reaction to that?
I'll react because I haven't reacted to anything yet. I think I've already told Brian it's a great question. I think it's just an expression of the economic and other power differences between the receiving countries and the sending countries. that has created this dimension. I always say in other places that it's been done for football, but not for the critical health workers, where I think in football, probably more than a fair price is paid. And how to negotiate this becomes a challenge. In our situation, for example, from the graph shown earlier by Mr. Dumo, if you take the numbers arriving in the richer countries, most of them are from Asia, even though it's a small proportion of their health worker population. For us, it's more significant. And I recall when I worked as director of HR in Ghana, the point from the British was, look, your numbers are too small for us to bother about entering a major agreement with you. And so that remains one of the critical challenges about how do we arrive at an agreement that is fair to all concerned. That's all I can say at this point. Thanks.
Thank you. So we are coming to the end
Can I just say something on that?
Oh, yes, please do.
Yes, no, thank you very much, because indeed, I mean, this question of the how you reach a fair deal on this topic, as it has been said by many previous speakers, the idea is not necessarily to restrict mobility, but to better share the cost and the benefits of mobility among countries. I think the reason why we emphasize, and Ibad had also mentioned that the role of ODA here is because we should recognize that there is no individual solution to that. This is global health workforce shortage is a global problem and should be addressed globally. Indeed, ODA is one of the instruments, but through ODA, there are many ways to act. For example, you should know that international students who are received and trained in destination OECD countries, the cost of that training is counted against ODA, included in the ODA. So ODA is not necessarily money flowing from one country to another. It can take several forms. What we say is that destination and OECD country should take their fair share in training enough professionals. That might not be enough. National policy response are also required, and I think the example of Sudan was very, very telling on that. It should take multiple forms, but again, OECD destination country should take their fair share and should increase or help other countries to increase their capacity in training and in retaining their workforce. ODA is not the panacea, but it's one of the instruments we have and we should use better and more.
Okay, thank you. I would like to thank everybody for being with us up to this time, and all your comments, those that have not been addressed, we shall continue on the blog at AfriHealth website, but I would like to give Professor Omaswa 2 minutes to give us some closing remarks. Thank you very much.
Well, I have enjoyed the 1.5 hours. The conversation has been very educative. The topic, like Ben Sims said, is permanent. It's not going to go away. I look forward to our continued engagement. One, the AfriHealth website, but also the HS website has this blog, which I issued the other day, which is being discussed. Let's continue also there, and any other channels that are there for dialogue. In particular, I would like to see OECD team up with the WHO, team up with the African group, the African Union, the African platform, and then our colleagues. I think I saw Roger Glass also on this webinar. Roger, are you still there? Of course, is muted. The US and the UK. Let's see how we can also get the civil society group, the likes of THED, the likes of the Health Workers for All Coalition, and the Global Health Workforce Network. let's create a group through coordinated by WHO IBADAT to take this work forward. It is urgently needed, and it is something which, if not well handled, will lead us to a more difficult situation when the next pandemic comes, as for sure it is going to come. So once again, thank you everyone, and look forward. Maybe we have another conversation like this in another 3 or 6 months time. And stay well, keep safe, difficult times. And I have learned the word, is it distance socializing from Joe Collas, which I had not used or heard about before. Thank you.
Thank you, Professor Omaswa. Thank you, everybody, for joining this webinar, and all our speakers. Thank you so much for your presentation. And as I said, we'll continue the conversation. There will be a recording of the webinar on the AfriHealth website. And stay safe, and we keep communicating and talking about this, because it is not going to go away. Bye, everyone.
Bye.